Good afternoon. So, today we're going to be talking a little bit about pain, and pain is probably the most common reason, actually, that people seek medical care in all of the United States. The pain experienced can significantly interfere with a person's quality of life, affecting nearly every aspect of their life, actually. So, for instance, severe back pain can affect a patient's job performance, um, engagement in social activities, sexual intimacy, sleep and rest, and the ability to exercise, and the ability to actually just perform activities of daily living. So these factors in turn can affect the intensity of the patient's pain as well as the patient's response to that pain. So pain can really cause a lot of sleep loss, irritability, uh, cognitive impairment, functional impairment, and immobility. And thus, it can be very destructive to the patient and the family, as well as their well being and healing process as well. So, there's a bunch of different classifications of pain. There's cutaneous or superficial pain, which arises in the skin or the subcutaneous tissue. And if you've ever touched a hot object, for example, or received a paper cut, you have experienced superficial pain. And although the injury is very superficial, it may cause significant short term pain. And then there's deep somatic pain, which originates in the ligaments and the tendons, nerves, blood vessels, as well as the bone. And deep somatic pain is more localized and can be described as achy or tender. A fracture or a sprain, arthritis, and bone cancer can cause this deep somatic pain. And then there's visceral pain, which is caused by the stimulation of deep internal pain receptors. So it is most often experienced in the abdominal cavity, the cranium, or the thorax. Visceral pain is not well localized, oftentimes, and it can be described as a tight pressure or crampy pain. The description of the quality and the extent of that pain oftentimes serves as a strong clue to the cause. So, some examples of this are menstrual cramps, labral pain, GI infections, bowel disorders, and some of the other organ cancers all produce this kind of visceral pain. The classification of pain, again, a continuation of that. Um, Radiant pain, for example, it starts at the origin of wherever that pain is coming from, but it also extends to other locations. For example, the pain of a severe sore throat may extend to the ears and the head, or the pain of an episodic gas GERD or gastroesophageal reflux or heartburn. Many people may say that it radiates outward from the sternum to involve the entire epithorax. So pain can radiate from the origin to other places. And then there's also a thing we call this as referred pain in an area that is quite far distant from the original pain. For example, the pain of a heart attack may be experienced down the left arm, through the back, or into the jaw. And then there's phantom pain, which, having been in the military for as long as I was, people who have their limbs blown off or we've had to amputate them, they may still feel pain in the extremity where the um, extremity's been removed, and it is perceived to originate from the area that's been surgically removed. And patients with amputated limbs may still perceive that limb. They may truly believe that it it truly still exists and experience the burning and itching and deep pain in that area, although it is not present. Psychogenic pain is believed to arise from the mind, obviously, and the patient perceives the pain despite the fact that there's really no cause that we can identify for that pain, so we really don't know what the etiology of that pain is. But psychogenic pain can be just as severe as pain from a physical cause. So basically, pain is whatever the patient says that it is. When we talk about referred pain, this slide just depicts some of the areas in which pain can originate, and as well as to where it can radiate, and the patient can actually say that they're feeling that pain somewhere else, even though it's not the origin of the pain itself. So, noroceptive pain occurs with the pain receptors, actually, which are also called noroceptors, respond to a stimuli that are potentially damaging. For example, as a result of a noxious thermochemical or mechanical stimuli, noroceptive pain may occur as a result of a trauma, surgery, or inflammation for that fact. Neuropathic pain, okay, is a complex and oftentimes a chronic pain that arises when injury to one or more nerves in that area results in a repeated transmission of that pain signal, even in the absence of the painful stimuli. So the nerve injury may originate from any of the variety of conditions, such as poorly controlled diabetes, for example, where we have diabetic neuropathies, or a stroke, a tumor, alcoholism, amputation, or viral infection, for some examples, shingles or HIV or AIDS, for example. So acute pain really has a very short duration, and it generally has a very rapid onset of that pain. It varies in intensity and can last up to anywhere from up to 6 months. So this type of pain is most frequently associated with injury or surgery, which you might experience or see in the med surge area. It is protective in that it indicates a potential or actual tissue damage. Although acute pain may absorb a patient's physical and emotional injury for a short time, it is helpful for the patient to know that it will generally disappear as the tissue heals. So I want you guys to think about the fundamentals of pain and the initial origin of pain. Okay, always starts with inflammation, and that inflammation results in the compression and or tissue destruction, which results in the pain transmission going to the nerves in the brain saying that hurts. Now, chronic pain, on the other hand, has lasted for 6 months or longer. So, and it often interferes with our daily activities, unfortunately. And patients with chronic pain may experience periods of remission and exacerbation. So there may be times where the pain is gone and not there, and then they do something and it exacerbates the pain and it continues on. So chronic pain is oftentimes, unlike acute pain, chronic pain is often viewed as insignificant and may lead to withdrawal and depression, anger, and frustration and dependence. So we always have to keep those things in mind. Um, Intractable pain is both chronic and is typically highly resistant to any kind of relief whatsoever. And this type of pain is especially frustrating for the patient as well as a care provider because we're trying to figure out how to address that pain. And it should be approached with typically multiple modalities of pain control, whether that be NSAIDs or opioids or pain patches or a cream or something like that. But regardless of that, we have to control the pain and make sure that we get some kind of pain relief. Otherwise, they're going to have a hard time carrying on with the activities of daily living. So, pain quality can be described. Oftentimes, if somebody says, I'm in pain, my next question is, where's the pain at? Um, how long has it lasted? What's the duration of that pain? What makes it feel better? And can you describe that pain? So, pain quality can be described oftentimes as sharp or dull, aching. Maybe they might say it's throbbing, it's stabbing, it's burning, it's ripping, it's searing or tingling. So, oftentimes, to get that out of the patient, a good question is, can you describe that pain for me? And obviously, we want to ask if it radiates anywhere, is it referred anywhere, does it go anywhere else? And obviously, as well, we want to know what the pain um, periodicity is. I mean, it can refer to be maybe it's episodic, once in a while, maybe something exacerbates that pain. Is it intermittent or is it a constant pain that just always exists and stays there? And pain intensity can vary depending on what kind of pain we're talking about. Um, is it, we want to know, is it described with a variety of terms, um, such as is it mild, is it distracting, is it moderate, is severe, or is it intolerable? And oftentimes, the best way to get that is to measure that on a scale of 1 to 10, 0 being no pain and 10 being the worst pain that you've ever had. Could you rate that pain on a scale of 1 to 10? And that gives us a decent number. But also know that pain is oftentimes very subjective. But to me, pain is whatever that patient says it is, and I'm going to treat that pain with whatever modalities I have available to me per the doctor's orders, or if I have to call the doctor for an order, I'll do that as well. So, when we're talking about the physiology of pain, um, there's a couple things involved here. Um, Obviously, we have neuroreceptors that become activated by the perception of mechanical, thermal, or that chemical stimuli, whatever it may be. Mechanical stimuli, for example, are external forces that result in a pressure or friction against the body, and they oftentimes involve the stretching of the body tissues, um, and that, you know, like I mentioned earlier, bleeding or swelling, inflammation, those all cause a compression of the tissues caused by the force of the trauma, and that causes the pain to be kicked off. Other types of mechanical stimuli are when we have surgery, those surgical incisions, friction or skin shearing, oftentimes from sliding patients up and down the bed, can oftentimes cause pain and cause skin injury, which results in that pain. Or we have pressure from mechanical devices such as a cast or a brace. So it can be a lot of different things that are caused by mechanical stimuli. Thermal stimuli result obviously from a exposure to extreme heat and or cold. So whether that be a frostbite or whether that be a burn, either of those can cause pain. And for example, I would say if you've touched a hot object or suffered an earache or went outdoors on a cold day without a hat, you've experienced a mild case of pain that's caused actually from the thermal stimuli or temperature of the environment around you. Chemical stimuli can be internal or external. Um, Lemon juice, for example, or any acidic substance, or an open area in the skin causes a sharp, sudden pain. So, if I wouldn't advise it, but if you have a cut on yourself and you pour lemon juice in there, I can tell you that's going to hurt like crazy. So that would be a type of a chemical stimuli. Or if you get a burn from a battery acid, is another example that I think of, which I've had personally. Um, that's caused from the chemical reaction from battery acid, which burns your skin and ultimately causes pain. So the transmission of that pain, okay, peripheral nerves carry that pain message to the dorsal horn of the spinal cord. And in a process known as transmission, that pain message is are actually conducted to the spinal cord and along either of these two pathways. So the A delta fibers are larger in diameter, and they are myelinated, excuse me, fibers that transmit impulses at about 6 to 32 meters per second, which is pretty fast if you think about it. These fibers transmit fast pain impulses from acute, focused mechanical and or thermal stimuli. And then there are your C fibers, which are smaller and they are unmyelinated fibers that transmit slow pain impulses. And that is basically our dull or diffuse pain impulses that travel at a slower rate. C fibers, however, conduct pain from mechanical, thermal, and chemical stimuli. So whether it be A delta fibers or C fibers, nonetheless, they all reach the brain at some point, hopefully, unless we're being treated with CNS depressants, or maybe it's a nerve block or something like that that's blocking those impulses to get into the brain where it can interpret that. So our pain perception basically involves the recognition and the interpretation of that pain in the frontal cortex of our brain, actually. And the pain threshold is the point which the brain recognizes and actually defines a stimuli as pain. If you've ever touched a hot stove, it touch it, and your brain goes, "Wow, that hurts," and then it tells your muscles to remove your hand from the stove, and that's a total example of how that works. Our pain tolerance, okay, is basically the duration or the intensity of the pain that a person can actually endure. So many of us have different pain intolerances. There are also some cultures that are very stoic to pain, and they're not going to tell you if it hurts or not. But if you've experienced a lot of pain in your life, if you've ever had trauma of any kind, your pain tolerance is probably higher than most anyone else. And this varies not only from person to person, but also from persons in different situations who've experienced extreme pain. So and then there's also pain modulation, which is the whole total process that changes the perception of the pain by either facilitating and or inhibiting those pain signals through the endogenous analgesia system. Uh, we also call it the gate theory, where it's believed that the analgesia system, our neurons in our brain stems activate descending nerves, fibers, that conduct impulses back to the spinal column, and these impulses trigger the release of endogenous opioids and other substances to block the continuing brain impulse and provide pain relief. So, indigenous opioids are naturally occurring analgesics and neurotransmitters that inhibit the transmission of pain impulses. The gate control theory that I mentioned earlier, we believe that these pain impulses can also be modulated at the spinal level. And in explaining the mechanism of pain perception, the gate control theory of pain modulates suggests that our perception of the pain does not only occur only by direct stimulation of the noroceptors or pain producing fibers. Instead, pain is perceived by the interplay between two different kinds of fibers, and those that produce pain and those that inhibit pain. This slide is just another depiction of how our pain goes through the dorsal root and goes up into our brain and is interpreted by our brain as pain and goes back to our muscle fibers and tells our muscles to move or to get out of the way or to try to do something to inhibit that pain. So our bodies react to pain in a variety of ways, but they can impact all of these systems, whether it be endocrine, cardiovascular, muscular, respiratory, genital, urinary, or the GI tract. It can affect all of them. As far as the endocrine goes, ongoing pain triggers excessive release of the hormones, adenocorticotropic hormone, also cortisol, and the ADH or the antidiuretic hormone, your growth hormone, your catecholamines, and glucagon as well. Insulin and testosterone levels also decrease, and these hormones shift active carbohydrate, proteins, and fat catabolism or the breakdown, and hyperglycemia and poor glucose use as well. The inflammatory process, okay, combined with these endocrine and metabolic changes, can result obviously in weight loss, tachycardia, fever, and increased respiratory rate, and even death if you get down to it. As far as your cardiovascular system, an unrelieved pain typically leads to hypercoagulation, which is increased clotting, and an increase in our heart rate, increase in our blood pressure, cardiac workload, cardiac O2 consumption, and as well as our oxygen demand. So the heart and the myocardia can suffer ischemia and basically can result in an infarction and or what we'd call a heart attack. As far as your musculoskeletal system, unrelieved pain oftentimes causes impaired muscle function, fatigue, and immobility. So overall, poorly controlled pain can prevent the patient from performing activities of daily living and engaging in physical therapy. So the whole idea there is to treat the pain as much as we can. As far as the respiratory system, patients in pain tend to breathe shallowly and typically rapidly to limit the thoracic and abdominal movement, and this is called splinting. So splinting reduces tidal volume, which is the air that is expired with each breath, and it increases your inspiratory and expiratory pressures as well. So these changes can lead to pneumonia, atelectasis, as well as underventilation or retained carbon dioxide, also called hypercarbia, and respiratory acidosis. So, um, treating pain with somebody who can't breathe is very important, or if they're not breathing because they have an incision. Sometimes the splinting with a pillow might help with the incisional pain, which will help them breathe more. So if someone's having a lot of pain, you might see somebody who has they're tachycardic, their blood pressure's up, and their respiratory rate is up, and we want to get them to slow the breathing down and encourage use of the inspirometer and those things to prevent the atelectasis and whatnot. So it is kind of a double-edged sword. We have to be careful because opioids also decrease their respiratory effort. As far as the GI system is concerned, unrelieved pain can cause the release of excessive amounts of catecholamines, aldosterone, as I mentioned before, the antidiuretic hormone, cortisol, and angiotensin 2, and prostaglandins. So these hormones basically can lead to a decreased urinary output, urinary retention, fluid overload, hypokalemia, hypertension, and increased cardiac output as well. So, in response to the your GI system, in response to pain, typically your interstitial secretions and smooth muscle tone increases, and gastric emptying and mobility or motility actually decreases. So it's very important for nurses to assess pain, and oftentimes pain is referred to as a sixth vital sign. So again, you're going to hear this over and over. Pain is very subjective, but pain is whatever that patient says it is, and that's why it's important for us to assess that pain and try to figure out what's going on with the pain. So an overall comprehensive pain assessment includes you might hear the term old cart, which you might want to look that up, but basically it includes the pain location. I want to know about the quality and the intensity of the pain, what aggravates that pain, and maybe what alleviates that pain, and the timing and duration. I want to know about what kinds of things allow them to have some pain relief, and what our goals for the pain is. So part of that is to figure out where their pain is and what might be tolerable to them. So to treat pain effectively, we first have to understand the patient's perception of that pain, and so we have to assess for that pain as it is a fifth vital sign. So whenever you're doing your vital signs, included in there should also be some type of pain assessment, whether it be on a scale of 1 to 10 or some other. If you're dealing with children, it might be another pain scale, but we need to try to assess that um, on a very routine basis, and I would say at a minimum with your vital signs. This is also, pain is also a Joint Commission patient safety goal, where when this initially came out, it was, we were finding that we were actually not doing a very good job of assessing pain. And so they came out and said that, you know what, you need to assess pain more often. And furthermore, you need to also treat that pain the best you can. There are some different pain scales here. There's the visual analog scale. I would say that the numeric rating scale is probably the most common, and then there's a Wong Baker face pain rating, which is typically used for children, which you'll see on the following slide. So here are the different ones. Typically, if you're dealing with a child, sometimes these faces might work for you, but more often than not, you'll be using the scale of 0 to 10. 0 being no pain, and 10 being the worst pain you've ever experienced in your life, whatever that is. And if we can find out where that is. Now, those numbers are going to also vary from patient to patient, so it's very important for us to establish maybe what is a tolerable pain for them. So a tolerable pain for one person might be a 2, a tolerable pain for another person might be a 5. So we need to kind of investigate and figure out where that's at and set a goal as to where we want to try to get them down to in terms of our pain management skills. And remember, there's always non-pharmacological um, pain modalities, whether that be deep breathing or whether that be imagery or some other things that may work for some people. But if you have a pain medication that is available and it's ordered and they can get it, you need to treat that pain. Do not hold back or do not reserve the right based on your own personal beliefs as whether or not treat that pain. If they can get the pain medication, I say, and it's my personal practice, I give it to them. It's not my job to sit there and judge that pain and say, well, they're really not in pain, or they are in pain, or they're not tachycardic, or their blood pressure's not up, and their respiratory rate's not up, so they must not be in pain. Or to go in there and, if someone's sleeping and they're complaining of pain, um, I might question that a little bit. But if they can receive the pain medication, I'm going to give it to them. So I'm not going to hold back any of that. So pain is basically, at the end of the day, is whatever that patient says it is. And you need to treat that pain as such. So there are some nonverbal signs of pain that we need to kind of cue in on. In addition to the patient's actual verbal reported pain, we also have to recognize some of these signals, and we have to pay close attention to the patient's physical signs and symptoms. And we will see the sympathetic nervous system kick in response to that pain if it is, in fact, acute. So, when assessing for nonverbal signs of pain, we want to keep some of these things in mind. You might see facial expressions, different posture, and body position, which are pretty reliable indicators of the intensity of the pain for the person. Um, Basic and common facial expressions and that signal pain are, maybe they're lowering the eyebrow, or they're wincing, grimacing, maybe they're clenching their jaws or closing their eyelids. Maybe they're guarding a painful area and don't want anybody to touch it. So, again, those sorts of things we've got to cue in on. Yes, we should probably see, in conjunction with a high intensity pain, we should probably see some changes in the vital signs. And it could be maybe for only a very short period of time. But the body typically will seek some sort of equilibrium, and thus, after an hour or so, maybe the vital signs typically return to a baseline, even though the patient may still be in pain. So those are not always an end all. So continuous severe pain uh, may elevate the vital signs, as we talked about earlier, but they will oftentimes remain elevated until we treat the pain. So, uh, a key point to this is that normal vital signs, I mean, if you go in and you see somebody have normal vital signs, they're complaining of pain, does not mean that that patient is free of pain, even though their vital signs are, for all intents and purposes, normal. So patients can be in pain even if they don't act like they're in pain. So we want to use, if you have somebody who has maybe there's a little bit of a language barrier, it's important for us to get an interpreter on site and see if try to get the information and assess that pain through an interpreter, perhaps. And there are some patients that feel that they're being bad or weak if they express the pain. So it's kind of part of our profession to kind of create that therapeutic atmosphere and environment where they can say that they hurt, and we're not going to judge that pain. So there's a lot of pain. There's a lot of patients who may withdraw from that sort of thing or that dialogue, or may also become very stoic. And for them to be very stoic means that they're actually in pain. You may see their vital signs all over the map up, and you know that they're in pain. And they're gonna, when you ask them about the pain and you try to get them to discuss the pain, they may be very stoic and not tell you they're hurting at all. So it's important that we establish kind of a trusting relationship with them and convey our concern and our passion that we want to take care of these patients, even though they want to try like they're a tough guy. So we have to treat that person's pain as whatever they say it is. Um, and if the patient actually trusts you, he or she will probably feel a little bit more free to verbalize those thoughts and feelings that they're actually having. So, with pain, we also have to keep another thing in mind. Depression is oftentimes overlooked in the patients with pain. If you can't get out of bed and you can't move around and you can't do your activities, daily living that you normally did before because you're just experiencing too much pain, that can cause a pretty daunting outlook on life as well as depression. So, a key point here is, according to NANDA, okay, which labels are pretty commonly used with pain, um, which is the focus of the problem. So we're going to have acute pain and chronic pain. And as I mentioned earlier, acute pain is probably less than 6 months, and chronic pain is something that they've experienced for a duration that's probably greater than that 6 months. So there's a lot of different pain management modalities. Um, there's obviously the oral sucrose, which by mouth or alone or in combination with other analgesic measures can be effective for pain control in newborns exposed to mild or moderately painful procedures. Immobilization is part of somebody who has a painful body part, and this is experienced oftentimes with fractures and some other injuries with splints and casts and whatnot. Um, can offer some relief if somebody who has a femur fracture, for example, if they're really hurting. Oftentimes, the retraction of that fracture can oftentimes provide some relief. So, and this immobilization is actually particularly helpful in people who experience um, arthritis, I guess I should say. So, there's some other things that we could do. There's distraction, there's sequential muscle relaxation, there's guided imagery, diaphragmatic breathing, hypnosis, therapeutic touch, there's humor, expressive writing, and animal assisted therapy, your pet therapy dogs. So there are some other non pharmacological things that we can attempt to try to help people control their pain. So, even though we may not prescribe necessarily non-opioid or opioid analgesics, whether that be a PCA, or maybe Vicodin or Percocet or Dilaudid or whatnot. There are also some other things that are non-opioid analgesics, such as your NSAIDs, which include aspirin, ibuprofen, and some of the others. NSAIDs typically act in the peripheral tissues by interfering with the production of prostaglandins, and those prostaglandins sensitize pain receptors and are involved, obviously, with inflammation. So, if we can provide a non-steroidal anti-inflammatory drug, oftentimes because it does address the inflammation, we can also control some of the pain with that. Um, Acetaminophen, however, oftentimes you'll see that prescribed, but it really has very little anti-inflammatory effects as far as that goes. Instead, it actually has an analgesic and fever-reducing properties. So, even though it has fewer side effects and is probably the safest um, in terms of non-opioids, it does not affect the patient's function, and it does rarely cause GI problems, but some people may complain of GI problems. And it can be used in patients who are allergic to aspirin and or NSAIDs. So there's also some adjunct analgesics which reduce the amount of opioids in the patient that the patient actually requires. And drugs in this category include things like anticonvulsants, antidepressants, local anesthetics, topical agents, patches, muscle relaxants, and corticosteroids, and there are some others, but basically those are all included in modalities of the treatment of pain. And then we have the opioid, which are basically uh, natural, and there are also some synthetic compounds that relieve pain. Although they vary in potency, they all kind of do the same thing. So you either stop the pain before it gets to the spinal cord, or you affect your CNS system, which by the time the pain gets to your brain is actually unable to interpret that pain because they're CNS depressants. So um, the opioid receptors typically focus on the mu, the delta, the kappa, and the sigma receptors. However, the mu receptors are the most effective in relieving that pain. But again, you're basically not really stopping the pain at the site, you're just stopping the brain's ability to interpret that pain. So there's something that you might see occasionally. It's called your PCAs, which are basically a client or patient controlled analgesia pumps, and they're effective and a safe way to deliver opioids by IV. It could be also epidural or subcutaneous routes, and they actually provide excellent pain relief and give the patients a sense of control over that pain. And the system consists of basically a programmable pump, which might have morphine and might have Dilaudid or Demerol or some other pain medications, where the pump can be set up that the patient hits a button and delivers a PCA dose to themselves, and every on an interval of every 6 minutes, every 10 minutes, or whatnot. And it can also have a basal rate or continuous rate where that pain is continuously going, and they can also deliver a dose to themselves. And those are typically, they will order a pretty low continuous rate of infusion, or what we also call a basal rate, that can be supplemented with the patient demand doses on an interval that is determined by the provider. Um, Often, a lot of thing that another thing that's kind of come on scene is the nerve blocks, and nerve blocks have been found to be pretty effective. People who, especially post-operatively, who may go under anesthesia, whether it be general anesthesia, they'll also give them a femoral block at the beginning or at the end, and that will provide them with maybe 12 to 24 hours of pain relief, because the nerve is knocked out. So the other thing that you'll see is local anesthetics, and those are basically, they inject to these relatively small areas of the body tissues to basically numb the area. And the other thing is called a beer block, and no, that's not like the beer you drink, but it's BIER. It's a beer block, and they use that, basically it numbs the whole thing, and they use short acting agents such as lidocaine or marcaine, and they can be with epinephrine or without epinephrine. The local anesthetics that they use with epinephrine tend to provide a longer pain relief, because the epinephrine causes a constriction of the vessels and keeps that pain uh, medicine in the area for a longer period of time. The other thing that's on scene is your topical anesthetics, which involve applying a cream or an ointment or a patch or something like that with lidocaine or benzocaine, um, directly to the skin, and the mucous membranes in the wounds or the burns actually absorb that, and it causes pain control to some uh, measure. So, if the pain can't be controlled by any of those other methods, and these things like radio frequency ablation therapy, which basically we use electromagnetic waves that travel at the speed of light, and we target these nerves that carry these pain impulses to our brain, and we zap them. And this procedure is used to provide longer term pain relief that is provided by injections of steroids, analgesics, and nerve blocks. So, surgical interruption of these pain conduction pathways results in absolute permanent destruction of the nerve pathways, and it's used as a last result of oftentimes for intractable in sorry intractable pain. Um, and the various options depend on the type and the location of where that pain is at. We can do a cordotomy, which interrupts the pain and the temperature sensations below the tract that we actually sever. And this is probably the most frequently done for leg and trunk pain. The rhizotomy interrupts the anterior and posterior nerve roots that are located between the ganglion and the cord, and the anterior interruption is generally used to stop spasmodic movements that accompany things like paraplegic people. Your posterior interruption eliminates pain in the area innervated by those nerves. So, this procedure may be safely performed at any level along the spine, actually, but most often it's used for head and neck pain produced by cancer for all intents and purposes. So, we also have a neurectomy, which is used to eliminate, again, intractable, intractable pain and localized pain. And these pathways for the peripheral nerves or the cranial nerves are basically interrupted to block that pain transmission to the brain. myectomy. Those sever the basically sever the nerves, um, the paths to the sympathogenic division of the autonomic nerve system, if you want to look at it like that. And this procedure we typically perform to improve the vascular blood supply and eliminate vasospasms. It is oftentimes used to treat the pain from things like vascular disorders such as Raynaud's disease. Um, these surgical therapies disrupting these pain pathways are not overall, they're not widely used because of the advances in oral and transdermal opioid therapies, which we talked about earlier. So the only time these are kind of like your last result, your last um, your last resort, I would say, for controlling pain. But they are sometimes used. So some special nursing considerations. And I want to address this because managing pain in elderly is kind of tricky. But pain, particularly presenting or persistent pain that goes on and on and on, is especially common among older adults, whether it be arthritis or some of the other things that go on, especially those that are suffering from degenerative spine conditions, arthritis, like I mentioned before. Maybe they're having nightly leg pain or pain as a result of cancer or osteoporosis or some of these other things. Um, it's a chronic pain, so we're to treat that. We're going to have to be kind of tricky. We can't just put everybody on opioids and Vicodin and Percocet and Dilaudid and some of the other ones. We're going to have to try to use probably some different types of modalities to treat that pain. So our older adults are actually at a greater risk for us to undertreat them because they, and as well as their care providers, may be a little reluctant to administer some analgesics for fear of producing confusion or excessive sedation or drug interactions or respiratory depression. However, I would say there needs to be a balance between managing the pain, treating the pain, and some of the other risks and benefits that might be associated with those drugs. And so those would have to be taken on by a case by case basis. So there is a risk, obviously, of maybe overtreatment as well as undertreatment due to the higher peak effect, as well as the longer duration of these pain relief methods that we have available, and they may experience as a result of associated with aging. So poor pain management can also result in falls, poor sleep, delayed healing, reduced activity, and prolonged hospitalization, anxiety, and poor quality of life. So there just needs to be a balance between treating the pain as what the patient says it is and considering their age and some of the risks and benefits associated with the treatment of those pain of that pain with opioids or non-steroidal anti-inflammatory drugs. For example, if somebody had a stroke, we'd have to be kind of careful with treating them with non-steroidal anti-inflammatory drugs or anything that would increase their bleeding. So really is a balance between treating the pain, keeping them comfortable, and managing the risks that are associated with that in terms of their age. Um, the other thing that comes out during pain management is managing clients who um, may have a higher incident of addictions. Now, addiction is basically a state of psychological dependence in which a person uses a drug compulsively and will engage in self-destructive behavior to obtain the drug. If any of you have watched 48 Hours or Drugs Incorporated, you may see where some of these people started out with a surgery and they were prescribed Percocet or Vicodin or oxycodone or some of these other drugs or OxyContin, and they take them over a long period of time, and then they become dependent on the drug, and then they say that people can become addicted and then end up going on heroin and cocaine and crystal meth, some of the other things. So a lot has changed between now and then. Uh, Oftentimes now, I believe that the treatment of an acute episode of pain, they can only prescribe, let's say, 20 pills, for example. When back in the day, they used to send people out the door, status post to surgery, with Percocet 60 to 90 tablets with two refills, and that kind of caused that. So I would also say there needs to be a balance between determining um, what people are at risk for addiction and treating that pain. However, um, many studies have actually shown that properly managed short-term medical use of opioid analgesics, okay, or those drugs, is actually safe and rarely causes addiction, with the exception of those with a personal or family history of drug abuse or mental illness. Now, so all that needs to be taken into context when we're treating someone with a pain. If it is an acute episode of pain, i.e., status post surgery, my personal feeling is to treat that pain. And I don't think that we should be overly concerned with addiction, because we need to treat that pain, because treating that pain is going to help them recover better. It's going to help them with their physical therapy. It's going to help them with turn cough and deep breathing. It's going to help with them with use of the Spanish spirometer, which reduces the risk of atelectasis and pneumonia and some of the other things that are associated with postoperative procedures. Chronic pain, on the other hand, is going to be a very touchy subject if you're dealing with someone who's relatively young and who has perhaps addictive behaviors, or maybe an addiction of some sort, and or a mental illness. So I think we just need to keep all that into uh, a, pers- a perspective in terms of treating their pain. And I don't think there's any reason why someone should be in pain if we have something that can help treat that. The other thing you might hear about is the use of placebos. Placebos are basically defined as any medication or procedure, including surgery, that produces an effect in a patient because of its implicit or explicit intent, not so much because of its specific physical and or chemical properties. So placebos actually contain inactive substances that actually do not have any chemical uh, properties that would provide any analgesic. And uh, clearly, I would say that placebos can relieve pain in some patients. Um, how they do so is not really truly well understood. I mean, if we give something and we tell them that, hey, this is going to help you with your pain, and they take it, and maybe it's a sugar pill, and they claim that their pain goes away, maybe a lot of it is mental, as far as that goes. So there are a lot of different theories, which include, operant conditioning and faith and anxiety reduction and endorphin release and some other things. But placebos, I haven't really seen a lot of those being used in terms of pain control. More so, placebos are oftentimes used for controlled double-blind studies where they give a certain group Percocet or Vicodin, and then maybe they give the other group a sugar pill. And you know, if the placebos are saying that's helping with their pain, you kind of got to ask, if it has no chemical properties to help with the pain, how does that work? So anyway, that concludes the presentation on pain. And hopefully you also watched the one with the perioperative uh, content as well. And the reason that pain is kind of wrapped up into the perioperative continuum of care is because that is oftentimes where nurses are found in the med surg ward, where they're actually taking care of patients post procedure. And pain is probably one of the primary interventions that, or the actually nursing diagnosis and interventions associated with that, that are going to be implemented to help that patient recover from surgery. So, if you have any questions or concerns, please feel free to email me and I'll try to answer you the best you can, or you can address me in lab or in the other clinical areas. So, I hope you enjoyed the presentation. Hopefully, it wasn't too long, and you guys just hang in there, and we're going to make it through all this COVID inertia.